And then that's the whole point. And that's the whole point of this. And then I'm trying to share my screen with you guys so that we can get on with yeah, here we go.
Can we just wait for 5 more minutes for a few people to join in? You can share your screen.
Yeah, we can.
So in that 5 minutes, we'll just introduce ourselves about what we are
Yeah,
doing, and yeah,
yeah, that would be great.
yeah, you can start, Satish.
Yeah. So yeah, that's about me. I've been doing emergency medicine quite long. So I'm from the first batch of 2014. So we completed in 2017, and I've been in emergency since then. And then I'm happy to see Pranav here. Hi, Pranav. I heard you.
Hi, sir. How are you?
I'm good, and I'm glad you guys are all doing so great.
Yes, yes. All because of good seniors like you.
Thank you for your kind words.
Yes, sir.
Over on to you, Harsha. You can introduce yourself.
Hi, I'm Dr. Harshavardhini Patel. I am also from the first batch of DNB emergency medicine. We all stepped out with awe factor for emergency, not knowing what exactly is emergency. But yeah, it's been a long journey so far. I currently am working as a consultant in St. John's Medical College for critical care medicine, and I've been practicing emergency medicine and critical care medicine. So this is just a look back to my roots. The whole ADRE RUSH EM is looking back to my roots. So then,
Yeah.
Yeah, Bhuvi,
Yeah.
about you?
Yeah, I'm Dr. Bhuvaneshwari Raja. I'm an emergency and critical care physician. Currently, I'm the head of emergency in Manipal Hospital, Bhubaneswar, and also an associate in critical care. So I've been in emergency for around 7 years now, like Satish and Harsha. And we are very happy to be in this program because when we started, we didn't have much guidance because we were the first batch, and there were not much of materials or resources for exams as well as for clinical practice, evidence-based practice. Though we were in a good institution with great number of cases, good seniors, good mentors, like we didn't have time for academics, and we didn't have a lot of support for evidence based emergency medicine. Like nobody was there to guide us. So our ultimate goal was to like help out all the juniors who are out there like us, like lost in the group or lost in the busy schedules. We just wanted to help all of you, like whomever is interested, to take that support and shine. That is about it. So we'll be
NB
starting.
protocol, the current NB, whatever competence base has come, I think after our batch, it's come like
Yes.
recently, if I'm not wrong.
Yes.
Our
Yes.
batch we didn't even have a log book. We knew only that we have to read internally book. And the first paper was the most scary day of our lives.
Yes. They could ask anything. They could ask anything.
Yeah. So this is our way to try and help out all of you to overcome the obstacles what we have faced.
Yeah, as much as possible with the recent evidences. And we want you to shine as a good academic person as well as a good practicing person. Like, there shouldn't be any mismatch between you and critical care people or any other department. You should know at par to their levels because you people are capable to know that. That we realized very later when we got the support and guidance from good people later.
So I think we can go ahead now.
Yeah, yeah.
Yeah.
Satish, you can start with the session if you are ready.
Yes, I'm ready. So let's go ahead. So welcome to ADRE RUSH EM. You can all see my screen.
The screen is not yet shared, like the PPT is not yet shared.
Oh, okay. Just a minute. Let me share it. Uh,
So bottom fourth option is
Yeah,
share.
yeah, yeah.
Yeah.
Yes, I'm trying
You have
to
to open the
share.
PPT and select that window.
Yes, I tried that. Just a minute. Okay, I think, yeah, that's gone down. Yeah, got it.
Yes.
Yeah?
Yeah, yeah. Put it on slideshow and you can start.
Yes. Yes, here we go.
Yes.
So at Rush EM, so we are starting an evidence-based emergency medicine e-learning platform. So this, our aim is to cater to all your emergency care practice needs, whether you're on clinical floor, whether you're practicals, whether with exams. We want to help you guide through all these things, and then with evidence, with backed with good evidence. What is the current evidence and where we stand with things. And then, as you know, it's a very rapidly evolving branch. There's a lot of new evidence coming up. And then it is a well-established specialty. And then I predict that it's going to do very well in coming years. So our vision is to create cutting-edge technology-based, evidence-based course in emergency medicine that will help everyone in practicing emergency medicine across the whole breadth of the country. And then our mission is to provide high quality evidence-based teaching. And then we would like uh, we would like to provide a comprehensive coverage, which which is exam-based as well, because I know most of you guys wants to give exams and then you want to shine in those exams. So we have compiled courses covering all the topics, and we'll be conducting mock tests, and then there'll be emphasis on previous year's exams and questions. And then we'll also cover practical aspects, ACLS, ATLS, procedures, and all these things. And then we'll be available 24 hours 7. I mean, time zones, I always thought time zones are tough, but it's easy now because Bhuvi and Harsha are in one time zone and I'm in one time zone. So there is someone always to respond to you guys. Please don't mind that. I'm in hospital. That's why you might hear some noises. And then coming to our modules, I'm going to briefly touch on our modules, what we're going to cover, so that you have a basic idea of what you are getting into. So coming to cardiovascular system, the most important system, I would say, we're going to cover ACS, hypertensive emergencies, inflammatory heart diseases, arrhythmias, valvular emergencies, heart failure, defibrillation, and cardioversion, cardiac arrest, and CPR theories. I'm sure Bhuvi and Harsha might remember. They asked us CPR theories in the first exam, and we were like, "What? We know what is CPR. We never knew what are CPR theories. What should we write?" So that post cardiac arrest care and obviously procedures. We'll cover procedures in each system, and then we compiled a procedure list, what you need to know, and then we will cover them comprehensively. So I'm going to skip the procedures in the rest of the systems. And then respiratory, pleural diseases, ARDS, mechanical ventilation in ARDS, strategies of ventilation ARDS, and then where do we stand at this point, and then pulmonary embolism, pneumonia, COPD, and asthma, along with touching with non-invasive ventilation, invasive ventilation, initiation of mechanical ventilation in these patients, and then with emphasis on oxygenation, along with basics of physiology of oxygenation. And then neurology, obviously, management of stroke, infections, CVA, neuromuscular disorders, spinal disorders, including spinal disorders, and then acute onset headache. And then GIT, renal, we're going to cover all acute abdominal emergencies, both medical and surgical emergencies, hepatic diseases, acute kidney injury, chronic kidney injury, CKD, renal replacement therapy, and then metabolic emergencies as well, like DKA. DKA, Addisonian crisis, and then all endocrine emergencies. And coming to obstetrics and pediatrics, I know you might be practicing pediatrics or not, but through this course, we'll help you get through the pediatrics because it's an important aspect of emergency, and then you will be asked to see pediatric patients at some point of time in your career. So we're going to cover how to approach a crying baby, what are the pediatric conditions which you should be worried, which you should not be worried. And when we cover cardiac arrest, we're going to cover obstetrics and pediatric cardiac arrest as well. And then we're going to cover trauma in both pediatrics and obstetric patients, and we're going to cover bleeding in pregnancies, hypertensive disorders in pregnancy, and we're going to cover non-pregnant emergencies as well, like gynecological emergencies as well through our course. And then trauma, ATLS, we're going to cover in and out of ATLS, including chest trauma, abdominal trauma, neurological trauma, and orthopedic trauma, and urogenital trauma as well. And then toxicology, we're going to cover principles of toxicology, including withdrawals, burns, temperature-related emergencies, altitude-related emergencies. And so that will cover toxicology. And we will also emphasize on specific toxins as well, which are important and which you see in day-to-day practice. And we'll also briefly touch on the rare toxins so that you're not caught off guard when someone asks you in exam or in a practical, because there is always an off chance of having one or two rare things in practice and even in exams. And then sepsis, we're going to cover an approach to sepsis along with an empirical antibiotic cover, which is in line with current medical council guidelines. And then we're going to cover tropical fevers, and we're going to cover miscellaneous infections, skin infections, soft tissue infections as well. And then coming to hematology and oncology, we'll cover anemia, both acquired anemia and congenital anemias, and then approach to bleeding patients, anticoagulation and their reversal. We're going to touch on major hemorrhage protocols, bloods and blood products, drugs, and then we're going to cover both oncological and hematological emergencies, which because now I think infections are coming down and cancers are going up as lifestyle changes. So we're going to cover that as well. And then along with that, we're going to cover eye emergencies, ENT emergencies, and psychiatry and dermatology as well. Each time you'll have one, or although you see less often in emergency room, but you do still see these emergencies, although they directly go to specialty centers, but it is important from the exam perspective. And then at the end of each module, we're going to conduct a mock test. We're going to give you a mock test, and then we're going to give a day for you to answer the mock test, and then we're going to give you the answer key, and then we are available to discuss this mock test. And then we're going to do case-based discussions on how to approach things. And at the end of the course, we're going to give 2 grand mock tests so that you are exam prepared, and then we are available 24/7, as I told you. So I think that would be from me, because I don't want to take too much of your guys' time, because we have a very wonderful session planned ahead by Dr. Harsha. I know that. And then with that, do you guys have any questions for me?
Yeah, please do ask, because this is a time where you can ask whatever doubts you have about the course and how we are going to go ahead. We are ready to answer. We are happy to answer, to clear your doubts.
Yeah, or if you guys want to reserve your questions to the last, even we are happy with that. And you can, I'm not sure whether you can drop in a message. Can they drop in a message?
In the chat box, they can. Yes.
Yeah, so drop in a message if you think that something comes to your mind and you'll forget, drop in a message so that we'll be able to answer that. Yeah, shall we move ahead then?
Yes, guys.
Great. Let's go ahead. Over to you, Harsha.
Yeah. So just give me a minute.
We can see few of our mentors are also there. We are so happy to see them, just to see how we are doing. Thank you for the support, Viju sir, Shailesh sir. Thank you so much. Thank you so much.
Okay, are you people able to see my?
Yes, yes. You have to do the screen sharing. It is loading actually. Now we can see. Now we can see.
Okay, yeah. So guys, now as we are going ahead, I would want to talk about the advances in cardiopulmonary resuscitation. So I think this is the very first task we are taught as we enter emergency medicine. The importance of cardiopulmonary resuscitation, I think we know better than any other specialty and any other people for that matter. Because I remember an incident when we were working as PGs. Satish was about to finish his duty and then he just received a patient who had collapsed in the hospital. The patient came back later date to thank Satish, and it was a wonderful moment. That very timely action saved a man's life, and nothing's more important than life. So on that note, we'll go ahead with the discussion. So this is the AHA 2020 guidelines for ACLS, that is for a pulseless patient. So the thing is, when did this all begin? This all began by about 1960, where the initial emphasis was we had Dr. James Ilan, who told that giving mouth to mouth breathing, we can actually help a patient inspire good oxygen. And then we had Peter Suffer, who combined this breathing efforts along with CPR. Okay, so finally, by 1960, they formalized the act of cardiopulmonary resuscitation, where it became a life-saving procedure. So, as you know, there is importance. Like initially, it began as breathing airway circulation. Over the time, many researchers told us that the emphasis is circulation airway breathing. So, based on circulation airway breathing, there were two proposed theories of CPR. The first theory was, when we give CPR, what exactly happens? That is the cardiac pump theory. In the cardiac pump theory, it simply means that when we are giving chest compression, the sternum and the the heart muscle is compressed between the sternum and the spinal cord, which helps to push out the blood inside the cardiac cavity, from the cardiac cavity, and aid in supplying blood circulation to the vital organs like brain and also some amount of coronary circulation. Then they discovered that it is not only the cardiac pump, also when we are giving CPR, the whole thoracic cavity acts as one unit. The pressure changes, intrathoracic pressure changes, also aids in bringing about circulation. From then on, we have moved to various other theories of coronary perfusion theory, cerebral perfusion theory, so on and so forth. The ultimate thing is, when we are giving compression, there is closure of your mitral valves, opening of your aortic valves, which brings about the forward flow. When we stop the compression, there is elastic recoil. It could be the recoil of the intrathoracic pressures, and as well as the recoil, relaxation of your cardiac muscle, which brings about opening of your mitral valve. And this aids in diastolic perfusion of your coronaries. So what exactly are the advances? I am trying to broadly discuss. Many areas are there where we can concentrate, beginning from BLS to ACLS to the post resuscitation care. But I have picked up three significant areas. That is, again, I want to discuss it based on circulation, airway, and breathing. So coming to circulation, in circulation, the very success of our cardiopulmonary resuscitation is based on high quality CPR. What does this high quality CPR mean? This simply means that adequate chest compressions with minimal interruption, trying to achieve the rate. It is not only the force of compression, also the rate of compressions with appropriate depth and allowing chest recoil. So, manual, this was about manual CPR. Then came the concept of using mechanical CPR. What is this mechanical CPR? This is nothing but automated devices are going to be providing chest compressions during a cardiac arrest scenario. So there are various types of manual CPR machines. One is load distributing bands, which uses the concept of using your whole thoracic cavity for providing compressions. And then the next one is your pneumatic piston devices, which uses the cardiac pump theory, where the cardiac compressions are given by compressing the sternum against the vertebral column, the heart in between the sternum and the vertebral column. Various devices were designed. One was our Lucas, or the Lund University Cardiopulmonary Assistance System by Stryker Medicals. And then you have the Autopulse. The Lucas is a pneumatic piston device. Then you have the Autopulse, which is by the Zoll Medical Corporation, which is a load distributing band. And then you have the thumper machines, and many more are there, like high impulse CPR devices. Then you have your vest CPR, phased chest and abdominal compressions, impedance threshold valves, and active compression decompression CPR devices. Let's not get into the physics of the instruments. Rather, we'll concentrate on how is it useful to us. As I told you, the main success, the key to success for cardiopulmonary resuscitation is the CPR quality. But what all can interrupt this quality? One is rescuer fatigue. We are all humans. After certain time of resuscitation, fatigue is one of the anticipated or expected outcome. Then we have interruptions in CPR. We need to do a lot of interventions. We need to secure the airway. We might not have a line in the patient, so getting an IV line. Also, if we think of one of the reversible causes, like if it's a toxin, or if it's a coronary event, or if it's a pulmonary embolism, we might have to intervene in these patients by giving thrombolysis or taking up for PCI. We have to transit the patient from the ER, emergency resuscitation bay, to the cath lab. So all of these can interrupt your CPR. Also, there is no actual measure of the depth and rate of compressions. Even with well-performed CPR, one can only achieve about 20 to 30% of normal cardiac output. As per the AHA, the use of mechanical CPRs by trained personnel may be beneficial where you don't have access to a reliable high-quality manual compression, or there is risk to personnel. This interest in mechanical CPR devices increased post-COVID, as we all knew that COVID could affect the healthcare workers as well. So there were various studies. Few of the studies which I've mentioned here, this is all conducted from 2014, 2015, during that times, where this is about out of hospital cardiac arrest. So out of hospital cardiac arrest of cardiac origin, Autopulse CPR use didn't actually show an added benefit with manual CPR. They just had an equivalent survival. Also in this study, they try to see the CPR fraction time, that is the amount of total resuscitation out of the total resuscitation time, what is the amount of CPR time which was given. There was no much change between using a mechanical CPR or a manual CPR. Neurological outcomes were not assessed. Then we have the link study, which again used Lucas and defibrillation. This didn't show any significant difference between the manual and the mechanical CPR. Even the paramedic study failed to show any survival improvement at 30 days. Overall, when it was used for out-of-hospital cardiac arrest, mechanical CPR devices failed to show any superiority over manual compressions. When it was compared to in-hospital cardiac arrest, there were studies which was conducted. It is very difficult to conduct a randomized control trial, because this is one of the life-saving measures where we can't withdraw a patient from benefit of the research or from benefit of the standard care. So somehow there were studies which were single-center randomized control trial among 34 patients. Though the ROSC rate, achievement of ROSC rate was higher among the intervention group, there was not much of added benefit by using a mechanical CPR devices. The last recent most study is the compress study, where 127 patients were studied for mechanical versus manual CPR. There was no difference comparing the rates of achievement of ROSC or survival to discharge or survival with good neurological outcomes at 6 months. So what is the advantage? When there is no study showing benefit, what is the advantage? See, where we can use this, when we have eCPR, or when there's a need for ECMO, or when there is prolonged retrieval, post thrombolysis or cardiotoxic drug overdosage to facilitate PCI, it can be used along with safe defibrillation as well. Yes, it minimizes the interruption. The major interruption is, as one of the disadvantage I've told you, time to set up this mechanical CPR. But there is less manpower utilization. So once, if you're relieving two people from giving chest compressions, when you know that the high quality CPR can be maintained, that manpower can be used for assessing the patient, or for finding out what could be the reversible cause of arrest, or what is the next best action. So the in that stressful environment, that could bring about cognitive offloading. The disadvantage is time to set up. Although there is a pit crew protocol, meaning they specifically the individuals are positioned in specific ways such that to minimize interruption. This currently is one size, but it is not necessarily that it can fit to all of them. The biggest barrier is cost, malposition is a risk, and the intensity of compression is so high that with the manual compressions we encounter fractures, which is not unusual. But there are also documented liver, splenic injuries, solid organ injuries, which might be detrimental for the patient. So ultimately, the current scope for research for using this mechanical CPR is, we need to figure out where all can we use this mechanical CPR devices, whether it is compatible when it is when the patient is in the cath lab or while establishing a ECMO, whether it is cooperative. I mean, can we go ahead with this mechanical CPR while establishing all these things, while during intervention, what is the use of this? And we need to tailor it according to patients' physic and body habitus as well. So high quality CPR is the key to successful resuscitation. I've been repeatedly telling this. Although mechanical circulatory support gives a new ray of hope, it cannot act as a substitute for manual CPR. It can just be used as an adjunct or bridge for manual CPR. Coming to the next strategy, that is airway and ventilation. So in this, this is a mechanical ventilation. Once the definitive airway is established in the patient, how can we ventilate the patient? According to AHA, currently you still bag mask the patient. So the current guidelines recommend to defer securing airway to avoid interruptions in CPR until ROSC is attained. If you are able to give good bag mask ventilation, there is no need for advanced airway placement. But as we all know, hypoxia is one of the reversible causes of cardiac arrest. In such patients, we might have to interrupt the CPR, secure the airway in order to revive the patient or achieve ROSC. It becomes very imperative to secure advanced airway to achieve timely ROSC. Securing airway and initiating positive pressure ventilation has found to be efficacious. So, how can we set up a mechanical ventilator? This is a big challenge because, as we all know, as much as CPR is important, good ventilation is also important. So, there was a strategy which was proposed to guide through positive pressure ventilation during resuscitation. So, what is the strategy? Using PEEP of 0, that is, it is told to use volume control mode of ventilation with 0 PEEP in order to avoid high intrathoracic pressures. As we all know, positive end expiratory pressure has hemodynamic consequences. It can impair our venous return, which we don't want in patients during cardiac resuscitation. So, mind you, people, what I'm talking is during resuscitation and not post ROSC. This mechanical ventilation strategy is while the CPR is ongoing. So, while the CPR is ongoing, You can adjust your ventilator. If the advanced airway is placed, you can adjust your ventilator to volume control mode of ventilation. Use 0P to avoid high intrathoracic pressures. Appropriately 8 ml per kg tidal volume should suffice adequate oxygenation targets in your patient. A respiratory RR of 10 per minute in order to avoid hyperventilation and thereby target a normal VQ ratio. P inspiratory pressure should be kept at maximum, because here you are giving chest compression, which the ventilator might sense as raised intrathoracic pressures, raised peak inspiratory pressures. So you have to keep it as high as 60 to 80 centimeters in order to just avoid your alarms. But there is a risk of barotrauma. Keep a careful watch about this, especially once the ROSC is attained. Then keep your trigger off to avoid auto triggering. IE ratio, you need to target IE ratio of 1:5, because the respiratory rate, in order to keep a target of 10 per minute. What is the limitation? It is applicable only in intubated patients. We can't use the same by using a NIV mask. It is not advisable. Rather, bag mask the patient. That is the best maneuver. Do not interrupt your CPR just to intubate the patient. No, this is proposed when hypoxia is the cause and when you know that advanced airway will help you gain back the ROSC. Also, it carries a risk of barotrauma. There's no much of studies which has been evaluating this strategy, and there's a scope for studies in this. Coming to the current highlighted topic, artificial intelligence and machine learning in cardiopulmonary resuscitation. So what is artificial intelligence? It is nothing but it's a comprehensive term that encompasses emulation of human intelligence into computer systems. So it is basically, you want our computers to think like us. Okay. So a part of artificial intelligence is your machine learning as well as deep learning. These use neuronal networks. There is various levels of programming in order to coordinate and bring out the actions. Machine learning is a part of artificial intelligence with supervised and unsupervised learning. I'll just simplify this term for you. You are programming your machine, giving the machine various data sets to recognize patterns, to identify images, or to recognize voice, language, speech style. And all this data is used for interpretation of few of our medical aspects. So how most commonly the best is, the whole basis is on pattern recognition. Artificial intelligence is based on pattern recognition. So the best fields currently evolving using this AI is our pathology, radiology, where it is all about pattern recognition. The next best fields are using precision, that is robotics. There is other fields like language skills are used, expert opinions are used. All of this is under evolution. So how can we inculcate in our emergency department? So pre-hospital emergency care, the goal is aimed at early recognition and dispatch protocols, bystander actions, activation, and post-resuscitation care. So this currently is a foreign data where 911 is activated for your emergency care. Copenhagen Emergency Medical Services used machine learning in order to recognize the telephone calls and thereby recognize the out-of-hospital cardiac arrest scenarios. Many a times when, depending on the symptomatology, what the patient's relatives or what the call was made for, anticipation of out-of-hospital cardiac arrest was done. Deep learning models have been used to improvise the precision of detection of shockable rhythms. And these models have been verified and they have shown to outperform our current early warning signs. So coming to resuscitation, AI has been exploring to assess the quality of CPR. The computer data from CPR training sessions as well as real life events are used to provide a real-time feedback. There was a pilot study which was conducted to show the quality of CPR, which actually didn't show any difference between giving a physical update to a AV feedback while the CPR was going on. AI can be used to anticipate cardiac arrest, therefore aid in timely recognition and resuscitation. And that is all the reason for smartwatches making people smart. So post-resuscitation and prognosis. So here the CT diagnosis and the clinical data was used. Machine-based learning models were used to detect highly accurately the 30-day survival post-arrest as well as survival to discharge. There were studies which showed 83% sensitivity of prediction of outcomes of survival. The CT images were processed using AI to detect hypoxic ischemic injuries, which outperform the current gray white matter ratio, which is currently used to detect our hypoxic ischemic injury. Limitations: the need for large annotated data sets is there. So we don't have data, though this is not an unusual scenario. CPR is something which probably every minute there is a person needing CPR, or it is less than a minute or more than a minute, but there is no actual data available. And the data from Indian studies is very, very poor when it comes to all of these things. Then also there is very scarce quality controlled rhythm notions. There are regulatory challenges. This data is very sensitive. These are machines. You can turn the machine to your benefit or to your destruction. Many movies have shown us that. So that is still a risk with using artificial intelligence. So AI is the tool. The choice of about how it gets to deployed is our choice. So with this, I'm open to questions.
That was a great class, Arsha. It was really good. Like I learned many things, truly.
Thank you. Thank you, Bhuvi. So I'm open to questions.
Anything about the class? Anything about the the
Orientation.
ADRE Rush EM per se? Hi, people. You can talk.
See, we would like all of you to switch on your video. We want to see you people. And let's keep it as an interactive session.
So, can someone from the audience answer me? Like, why that cap sequence was created? Why it is circulation, airway, and breathing? Can one of you answer?
Come on, guys. We want to see you all.
Yeah, Swapan. Hi, thank you for the compliment.
Heads up.
Swapan. Yeah, please, one of you, can you answer? Like, why the sequence was created? CAB, CAB.
You should unmute yourself, doctor.
No one? Prithvi, Sachin, Sheila. So, only perfusion is important, oxygenation is not important. So, unoxygenated blood going to the organs is also be like it's not good, right? So, why so that sequence is created? CAB. So the blood can remain oxygenated for 4 to 6 minutes after a single breath. But perfusion is not like that. You have to keep perfusing so that the oxygenated blood gets moving on to the organs, right? So that is why we start with CPR and then we oxygenate once because it can stay up to 4 to 6 minutes. That is like the basic physiology of CAB. And can someone tell me why how long we have to keep resuscitating if suppose a patient is having pulmonary embolism? How long we have to keep resuscitating? You have thrombolized, and how long you should continue the CPR? Great, Swapan. You can unmute and talk to us. Yes.
We would love to hear you.
Yes. And what is the dose of thrombolytic you would give for the PE? Okay, we understand. Thank you for joining, even being on duty. Thank you. So can someone tell me what is chest compression fraction? Yes, guys? Okay, we understand that you people are busy. So this completes our orientation session. Anything at all, you can get back to us in the WhatsApp. We are there in all social medias. ADRE Rush EM is there in all social medias, literally in Instagram, Facebook, LinkedIn, WhatsApp, everywhere it is there. Anything at all you need, you can get back to us. We would be happy if you feel that this session was good, and this will be the quality of all the sessions. We will be not only taking from Tintin Alley, we will be taking materials from Rosens and all the textbooks of emergency, as well as the recent evidence-based contents, because our genuine goal is to give a quality content. We want our juniors who are coming out of the course should be like a person who knows the recent evidences also, along with the basic physiology, because we miss on that. So we would be happy if you could join us. The quality of the content would remain the same with all the possible resources. We would definitely give you the quality content. And anything at all you want to tell, Harsha and Satish, you can please tell.
Yeah, so see, as Dr. Bhuvneshwari told, we are available on all the social medias. Also, we are trying to upload few lectures on YouTube to help you all out. See, we would like to have this more interactive rather than monotonous, even during the lecture sessions. So currently, we have few students who have joined and they requested us for a live and recorded session. So that is the whole plan. Probably today you guys are in between your work, and that's why, or this is the first time you're seeing us, and that's the reason you're not able to open up or interact. But we would love your feedback on this orientation, as well as we would love your feedback if you have our contacts or even the contact in our brochures. You can message us, you can ask us your personal request, how we can make this more useful, and how it can be tailored for your needs. So it was very nice that you took your time off to join today's session. I would like to thank all the participants who have joined us, and all the best. And we would want to see you being a part of ADRE Rush EM as well. Thank you, guys.
And
Satish.
to answer your question, Manikandan, it's both offline and online. We have online classes as well, and then we'll be uploading all online classes videos to an offline platform, and you'll be given access to that. Manikandan just asked if it is just offline classes or online it's just online or offline as well. So we do both.
So the same class will be recorded, and you will be given a link to access that recorded class.
Guys, you all are messaging on the group and answering.
Nice.
We would really like to see you people as well
And talk to you guys,
Yeah.
so that we could understand the need of the program.
Yes. Okay.
So this would finish our orientation session. We are busy too, but still, yeah. Thank you, guys. Thank you for being here. Thank you.
Thank you so much.
Bye.